Okay, so it's cornea and conjunctival foreign bodies. The symptoms the patients present would be foreign body sensation, tearing, and history of trauma. The signs, critical signs is conjunctival or corneal foreign body with or without a rustering. Workup in history determine the mechanism of injury. For example, metal striking metal, power tools or weed whackers may suggest an intraocular foreign body. Direct pathway with no safety glasses, distance of the patients from the site, etc. Attempt to determine the size, the weight, velocity, force, shape, and compositions of the object. 2. Document visual acuity before any procedure is performed. 1 or 2 drops of topical anesthetic may be necessary to control blepharospasm and pain. 3. Slit-Lamp Examination. Locate and assess the depth of the foreign body. Examine closely for possible entry site. You've got to rule out self-sealing lacerations, pupil irregularities, iris tears, and transillumination defect. Capsular perforation, lens opacity, high femur, anterior chamber shallowing, and asymmetrically low IOP in the involved eye. If there is no evidence of perforations, evert the eyelids and inspect the fornices for additional foreign bodies. Double evert the upper eyelid with a Desmere eyelid retractor may be necessary. Carefully inspect a conjunctival lacerations to rule out a scleral lacerations or perforations. Measure the dimensions of any infiltrate and the degree of any anterior chamber reactions for monitoring therapy response and progressions of possible infections. Dilate the eye and examine the posterior segment for a possible foreign intraocular foreign body. Treatment. For corneal foreign body, superficial or partial thickness, you can apply topical anesthetic, for example, proparacaine. Remove the corneal foreign body with a foreign body spud, fine forceps, or small gauge needle at a slit lamp. Multiple superficial foreign body may be more easily removed by irrigation. Note, if there is concern for full thickness corneal foreign body, explorations and removal should be performed in the operating room. 2. Remove the rustering as completely as possible on the first attempt. This may require an ophthalmic burr. It is sometimes safer to leave a deep central rust ring to allow time for the rust to migrate to the corneal surface, at which point it can be removed more easily. 3. Measure the size of the resultant corneal epithelial defect. And treat as for corneal abrasions. Alert the patients to return as soon as possible if there is any worsening of symptoms. Conjunctival foreign body. 1. Remove the foreign body under topical anesthetic. Multiple or loose superficial foreign bodies can be removed with saline irrigations. A foreign body can be removed with a cotton tip applicator soaked in topical anesthetic or with fine forceps. Small, relatively inaccessible buried subconjunctival foreign body may sometimes be left in the eye without harm unless they are infectious or pro-inflammatory. Two, sweep the conjunctival fornices with a glass rod or cotton-tipped applicator Soak with a topical anesthetic to remove any remaining pieces. A topical antibiotic may be used. Follow-up 1. Corneal foreign body. Follow-up as with corneal abrasions. If residual rustling remains, re-evaluate in 24 hours. For conjunctival foreign body, follow up as needed or in 1 week if residual foreign body were left in the conjunctiva.